Okay, let's dive in. We're focusing today on osteogenesis imperfecta, OI, often called brittle bone disease. And this is specifically for you, for your MSRA revision needs.
Exactly. Think about bones fracturing super easily. It's a striking condition.
It really is. So our mission here is simple. Pull out the absolute key information on OI from our notes, make it clear, memorable, basically everything you need to know for the exam.
Right. And we'll cover the whole spectrum, what it is, the definition, the causes, etiology, risk factors, what's happening biologically, the pathophysiology.
What else it could be? So differentials, how common it is, epidemiology, the clinical features, all those different types.
And then investigations, how we manage it, the prognosis, and potential complications down the line.
And crucially, because this is revision, we'll sprinkle in some memory aids, mnemonics, things like that to help it stick. Sound good?
Perfect. Let's start with the basics. What actually is osteogenesis imperfecta?
Okay, so fundamentally, OI is a genetic disorder. The core problem is defective collagen, specifically type I collagen.
Right. And that faulty collagen means the bones are fragile, brittle, prone to breaking much more easily than they should.
And it's not just bones, is it? That's important.
Yeah.
Collagen is everywhere.
Exactly. So you see effects in other collagen-heavy tissues. Think teeth, that's dentinogenesis imperfecta. We'll get to joints, tendons, even things like heart valves and skin.
It's systemic, really. And you mentioned types.
Yes, there are 7 main types currently classified, and they vary hugely in severity and the specific genetic cause. Understanding these types is pretty crucial.
7 types. Okay. And how is it passed on?
Mostly autosomal dominant, so you only need one copy of the faulty gene. That means inheriting it from one affected parent gives a 50% chance.
But it can also just appear.
Yes, new dominant mutations happen, so you can have OI without any family history. It's not always inherited.
Got it. And genetics-wise, there are specific genes involved.
Oh, yes. The big ones responsible for about 90% of cases are COL1A1 and COL1A2.
COL1A1 and COL1A2.
Okay. These genes basically hold the instructions for making type I collagen, so a mutation there directly impacts that crucial protein.
90%. That's huge. So OI equals type I collagen problems, mostly.
Pretty much. But it's also key to remember there's massive variation in how it presents the phenotype. Even within the same type, symptoms can vary quite a bit.
Okay, let's break down those 7 types then. What are the key differences for revision? Let's start with type I.
Right. Type I is generally the mildest. The issue here is more about quantity. There's less normal type I collagen produced.
So not necessarily bad collagen, just not enough of it.
Essentially, yes. This leads to bones that are more porous, kind of like osteoporosis. You might see abnormal or just lower levels of the pro-alpha 1 or 2 collagen chains.
Okay, and clinical features for type I.
Fractures, obviously, but maybe not starting right at birth. Thin sclerae, the whites of the eyes look bluish because you can see the veins underneath.
Ah, the classic blue sclerae.
That's the one. Also, weak tendons, sometimes thin heart valves, maybe a dilated aortic root.
Got it. Memory tip time. Maybe think of fair mild and the blue sclerae like a blue sky.
Nice one. Okay, then type 2 is the polar opposite. It's the most severe, often lethal form.
Lethal. So this is diagnosed very early.
Often in utero, yes. It's usually from new dominant mutations causing severely defective collagen. We see multiple fractures even before birth, very short, bowed limbs, and a really disorganized bone structure.
A devastating form. Okay, type 3.
Type 3 is classed as severely progressive and deforming. Here, the collagen produced is structurally abnormal, and often there's less of it, too.
So the deformity gets worse over time.
Exactly. Fractures are present from birth, deformity increases, often leading to extreme short stature. A key feature here is dentinogenesis imperfecta, or DI.
DI, those characteristic sort of opalescent, weak teeth.
Precisely. And also watch out for a triangular face shape and risk of respiratory problems from kyphoscoliosis.
Another memory tip. There are think severe, maybe 3 key things. Early fractures, progressive deformity, dental issues, DI.
Helpful. Okay, type 4. Moderately severe. It's typically autosomal dominant. The big differentiator from type I is that the sclerae are usually white, especially in childhood.
White sclerae, okay.
Ah.
So if you see recurrent fractures, but not blue sclerae in a child, think type 3 maybe.
That's a good pointer, yes. Severity-wise, it sits somewhere between type I and type 3.
Right. Then we have the less common ones, V, C, 6, 7. What are the headlines for these?
Okay, type V, moderately deforming, fragility is moderate to severe, but sclerae are normal. Look for ligament laxity, calcification between the forearm bones, the interosseous membrane, and radial head dislocation. Bone biopsy has a specific mesh-like look.
Interesting. Type 6.
Also moderate to severe, but the key here is a mineralization defect. You get this buildup of osteoid unmineralized bone matrix.
So the bone doesn't harden properly.
Exactly. Frequent fractures, sclerae can be white or faintly blue. Importantly, no dentinogenesis imperfecta, which helps distinguish it from type 3. And weirdly, the gene defect isn't known for this one.
Still some mysteries then. And finally, type 7.
Moderate to severe again, but this one is autosomal recessive.
Ah, recessive, different inheritance.
Yes. Fractures often at birth, bluish sclerae, lower limb deformity, and something called rhizomelia, where the upper parts of the limbs, like thighs and upper arms, are disproportionately short. The genetic locus is known for this one.
Okay, that's a lot to take in, but the key differences are there. So just to recap the genetics and inheritance.
Primarily autosomal dominant, as we said. That covers most cases driven by mutations in COL1A1 or COL1A2 in about 90% of people with OI.
Affecting typology and structure or quantity.
Right. But don't forget the new dominant mutations causing sporadic cases.
And the rarer recessive forms.
Yes, like type 7, they involve different genes, CRTAP, FKBP10, others. These genes are often involved in sort of processing or folding the collagen correctly. So different mechanism, same outcome, faulty collagen.
And there was another dominant gene mentioned.
IFITM5. Linked to dominant OI, seems to play a role in bone mineralization rather than collagen structure directly.
So it's mostly collagen, but not exclusively. And all this genetic variety explains why the presentation, the phenotype, varies so much.
Precisely. Which brings us neatly to etiology, the underlying cause.
Which we've basically covered, right? It's the genetic mutations affecting type I collagen.
Exactly. Either affecting its production or its structure. Passed down dominantly usually, sometimes recessively, or occurring spontaneously. COL1A1 and COL1A2 are your main culprits to remember.
Okay. And risk factors. Seems pretty straightforward if it's genetic.
It mostly is. The biggest risk factor is having a family history of OI because of that dominant inheritance pattern mainly.
50% chance if one parent has it.
Right. But again, remember, sporadic cases mean anyone could potentially have a child with OI even without a family history.
Okay. Let's get into the pathophysiology. What's the mechanism making the bone so weak?
It really boils down to that faulty type I collagen. You either don't make enough of it or the collagen you do make is structurally flawed.
And type I collagen is like the main scaffolding protein in bone.
Exactly. It provides the tensile strength, the resilience. If that scaffolding is weak or incomplete, the whole structure, the bone matrix, is compromised.
Like a building with dodgy rebar.
Good analogy. It just can't withstand normal stresses, leading to easy fractures. And the severity, as we saw with the types, depends entirely on how bad the collagen defect is, which is determined by the specific gene mutation.
Makes sense. Now, if you see a child, especially with lots of fractures, OI is high on the list. But what else should be on your mind? The differential diagnosis.
Very important. For newborns and infants with severe fragility, you have to consider other severe genetic skeletal problems like achondrogenesis or thanatophoric dysplasia. These are types of dwarfism. Also, asphyxiating thoracic dystrophy. They usually have quite distinct features on X-ray.
Okay, and the really critical one in childhood.
Non-accidental injury, child abuse. Absolutely crucial differential. Needs careful history, examination, and often liaison with other specialists. Never miss considering it.
Definitely one to flag for revision. What about older kids or teens?
If the fragility is maybe less severe or presents later, you might think about idiopathic juvenile osteoporosis, low bone density, without a clear cause.
Got it. Okay, so how common is OI? Epidemiology.
The exact UK number isn't pinned down, apparently, but the worldwide estimate is around 1 in every 15,000 to 20,000 live births.
So considered rare, but not vanishingly so. You'll likely encounter it.
You will. And importantly, it affects all ethnic groups and both sexes equally. No known bias there.
Okay. Clinical features, then. We know it's variable, but what are the common themes?
Frequent fractures are the hallmark, often from minimal or no obvious trauma. Bone deformities, bowing of long bones, scoliosis, that sort of thing. Short stature is very common across most types.
And outside the bones?
Joint laxity, hypermobility. Those blue sclerae we talked about, though not always present. And hearing loss is common, often developing later, maybe in adolescence or adulthood, usually conductive.
And the really severe cases?
Fractures can happen even before birth or during delivery. It just highlights how incredibly fragile the bones can be.
Let's quickly revisit the types with these features in mind. Type 1.
Mildest. Fractures start maybe around birth or infancy, about 7 times higher fracture rate over a lifetime. Adults often get vertebral osteoporosis, usually not much progressive deformity in childhood, maybe some skull weirdness like Wormian bones, sometimes dental issues, the blue sclerae, joint hypermobility, and even cardiac things like leaky valves or a widened aorta. Remember, IMR, many features, blue sclerae.
Okay, type 2.
Perinatal lethal, often diagnosed prenatally. Severe short stature, bowed limbs, soft skull, deep gray-blue sclerae. Thing 2 looks like short, bent limbs.
Grim. Type 3.
Severely progressive. Fractures at birth, deformity gets worse, triangular face, very short stature, risk of chest problems from kyphoscoliosis. And remember, Dentinogenesis Imperfecta, DI, key features. Fractures early, deformity progresses, dental issues.
Got it. Type 4.
Moderately severe dominant inheritance. Can present at birth or later with fractures. Key point. Normal white sclerae in childhood. Complication can be hyperplastic callus formation after fractures. Think IV, moderately severe, ivory white sclerae.
And types V's, 6, 7, quick reminders.
Type V, mod severe fragility, normal sclerae, lax joints, forearm membrane ossification, radial head dislocation. Type 6, mod severe, mineralization defect, osteoid buildup, frequent fractures, white faint blue sclerae, NODI. Type 7, mod severe recessive, fractures at birth, blue sclerae, lower limb deformity, rhizomelia.
Okay, clear. So how do we confirm the diagnosis? Investigations.
It's usually a combination. Clinical picture, thorough family history, any relatives with similar issues. And then genetic testing is often the clincher. It identifies the specific mutation and helps confirm the type.
And imaging.
X-rays are vital. They show current fractures, old healing fractures, bone deformities like bowing, maybe Wormian bones in the skull.
What about bone biopsy?
Can be done sometimes to look at collagen structure directly, especially if genetics are unclear, but less common now with better genetic tests.
And blood tests. Calcium, phosphate, etc.
Usually normal. That's a key point for your exams. Adjusted calcium, phosphate, PTH, alkaline phosphatase, typically all normal in OI. Helps rule out metabolic bone disease.
Good tip. And prenatal diagnosis.
Possible for severe forms. Ultrasound can pick up fractures or short limbs. Then things like CVS or amniocentesis allow for genetic testing on fetal DNA.
Right. So once OI is diagnosed, what's the management strategy?
It's all about managing symptoms and preventing complications. Goals are prevent fractures, minimize deformity, manage pain, maximize mobility and quality of life.
It's like a team effort.
Absolutely. Needs a multidisciplinary team. Orthopedics, physiotherapy, pain specialists, occupational therapy, maybe specialist dentists, audiologists, plus assistive devices like splints or wheelchairs if needed.
And support.
Crucial. Genetic counseling for the family, discussing inheritance risks, and psychosocial support is vital for the individual and their family dealing with a chronic condition.
What about medical treatments? Drugs.
Bisphosphonates are the main medical therapy. They help increase bone density and reduce fracture frequency. Can be given by mouth or IV.
And surgery.
Often necessary. Intramedullary rods, metal rods inserted inside long bones are common to stabilize them and prevent fractures or correct bowing. Surgery might also be needed for scoliosis, correcting other deformities, osteotomies, or sometimes soft tissue procedures like Achilles tendon lengthening.
Any specific surgical challenges?
Yes, anesthesia needs care. The bones are fragile during positioning. There's also a potential risk of malignant hyperthermia, increased sweating, and breathing issues, especially with chest deformities.
Anything cutting edge?
For very severe cases diagnosed prenatally, there's experimental work on in utero mesenchymal stem cell transplants, trying to improve bone before birth. Still highly specialized, though.
Okay. What about the long-term picture? Prognosis?
Hugely variable, depends entirely on the type and severity.
So type 1.
Generally a better prognosis. Fewer fractures, less deformity, more active life, usually, but still an increased fraction risk throughout life, especially later on. Often normal or near normal life expectancy, same for type 4 usually.
And the more severe types.
Type 2 is often lethal. Type 3 can lead to significant disability, chronic pain, wheelchair use is common, and potentially a reduced lifespan due to complications, particularly respiratory ones.
Important considerations. What about recurrence risk for parents?
If parents have had a child with, say, type 2 OI, the recurrence risk in future pregnancies is significant, even if they themselves aren't affected, due to gonadal mosaicism or recessive inheritance. Prenatal diagnosis options like CVS in the first trimester are important to discuss.
Right. Finally, let's summarize the main complications of OI.
Number 1 is recurrent fractures leading to chronic pain and progressive bone deformities.
Which impacts mobility.
Exactly. Reduced mobility, joint problems like early arthritis. Hearing loss is a common complication.
The dental issues.
Dentinogenesis imperfecta, needing specialist dental care. And in severe cases, respiratory problems from chest wall issues and scoliosis can be serious.
So it often means significant physical disability and lifelong medical needs in severe cases.
It can, yes. It requires ongoing care and support.
Okay, so wrapping up, osteogenesis imperfecta, a spectrum of genetic conditions all about faulty collagen leading to brittle bones and other issues. Different types, different severities, needing multidisciplinary management.
Hopefully this deep dive has given you a really solid, high-yield framework for your MSRA revision. Remember those key gene names, the basic defect, and the distinguishing features of the main types.
Yeah, maybe making that table comparing the types inheritance, sclerae, DI, severity would be a really good revision activity. Understanding that collagen link is key to everything else.
Definitely. And if you want more detailed resources or practice questions to test yourself, head over to passthemsra.com.
And for extra free study materials, don't forget freemsra.com.
We hope this has been useful. Best of luck with your revision.